Here at the Melanin Initiative, we simplify medical information into language you can understand. We create a safe space for you to ask your questions and share a nursing perspective. Today, we'll be joined by first-time guest, Dr. Willa Smiley, a doctoral-prepared nurse. She's been kind enough to come on and help us continue our conversation about medical cannabis. If you're new here, welcome to the Melanin Initiative. I'm Dr. Kimberly Madison, a doctorally prepared nurse practitioner, and I co-host this show with Alicia and Geraldine, who send their love in their absence. We're a health literacy podcast. When we say health literacy, we're talking about your ability to obtain information, to understand that information, and then to use it to manage your health and advocate for others. Our mission here is twofold. The first is to simplify that health information so that you feel empowered, educated, and confident. The second is to elevate the expertise of nurses, to spotlight all the diverse career opportunities that are within the healthcare industry, and to inform our peers all the many ways that they can leverage their expertise as clinicians and entrepreneurs, as Dr. Smiley is going to do with us today. If you haven't already, this is your chance to subscribe, leave a comment, give us a thumbs up, rate us on Apple and Spotify. When you engage with our content, it shows the algorithm this information is important so that when people like you look for information like this, we'll show up higher in the search results. This show is for educational purposes only. The opinions expressed here are opinions alone. They are not a representation of any of our affiliations. If you think you might be experiencing a medical emergency, you should seek medical attention and medical guidance from your healthcare provider. If you think you might be having a physical emergency, you should call 911. If you or someone you know might be having a mental health emergency, you can call 988 or you can text 741-741. Ladies and gentlemen, today we have the honor of hosting Dr. Willa Smiley, a distinguished nurse leader whose multifaceted expertise spans clinical practice, wellness education, and healthcare advocacy. She holds an impressive array of qualifications, including a Doctor of Nursing Practice degree, a Master of Business Administration, a Master of Education, and a Master of Science in Nursing. Dr. Smiley's commitment to advancing nursing practice is exemplified by her recent achievement in implementing the Cannabis Use Disorder Test, a project that underscores her dedication to integrating evidence-based tools into clinical settings. Beyond her clinical and academic accomplishments, Dr. Smiley is a recognized leader in performance enhancement, empowering healthcare professionals, corporations, and individuals to develop practical wellness skills that drive impactful results across diverse settings. She's one of 4 mentees participating in the 2025 spring cohort of the DMPs of Color, My DMP Manuscript Mentorship Program. Today, she joins us to share her insights on the evolving landscape of medical cannabis, addressing critical topics such as industry trends, stigma reduction, safe access, and the role of healthcare providers in patient education. Please join me, everyone, in welcoming the award-winning nurse, author, and wellness educator, Dr. Willa Smiley. Welcome, Dr. Smiley.
Thank you. Thank you for having me. And it's an honor to be here with all of those. Sometimes you forget all the things that you've done. You just kind of brought it to light. Thank
Yeah.
you.
Once you get on that momentum, you keep going and you
Mm-hmm.
kind of forget that that wasn't the destination. Like you reached your destination.
Mm-hmm. Yep.
But
Takes
we're
a minute,
delighted.
but you get there.
Yeah, we're delighted for you to come on and continue our conversation about medical cannabis. We previously had this conversation with Ashley Wynn Grimes, who was kind enough to join us during our Breast Cancer Awareness Month in 2024 of October to talk to us about it. So we've started that conversation. We're going to have Angie, our producer, start a playlist now on medical cannabis so our audience can easily access that. And today we're really excited because we're going to get into those industry trends and we're going to give people actionable advice. I'm really excited to talk about Nurse's Guide to Visiting a Dispensary. I think that's going to be fantastic. It's the name of your upcoming book. And so we're just announcing to the audience now that they can look out for that.
Yes, definitely. Definitely.
So we're going to play a little game with you before we get into our topic. It's called
Sure.
5 Questions in 5 Minutes. We want to
Okay.
give credit to Nancy Twine. She's the host of another podcast called Maker's Mindset for this idea. And so it's meant to be fun and to get to know you a little bit better, okay? So what's the best thing that never happened to you?
The best thing that never happened to me. That's a loaded question. What's the best thing? The best thing that never happened to me is that I never lost sight of my goals and the things that I wanted to do.
Yeah,
Yeah.
I love that. When I heard that question, I loved it because there's so many things we go after, and we think it gives us more value, right? But then
Mm-hmm.
sometimes, the curves and twists of life, when we look back, we realize, actually, I'm glad I got fired. I'm glad that relationship ended. I'm glad I moved away.
Mm-hmm.
I'm glad it didn't work
Mm-hmm.
out. And so
Yeah.
when I heard that question, I thought, that's a way to really express gratitude for the things that
Mm-hmm.
didn't work out.
Yeah.
Okay, what's the next big idea you want to be a part of?
Research. I have three really. Once I did the cannabis, I want to work with nurses at all levels, from the home health aides, because they're the primary caregivers and they're like first responders, first on everything. Uh, as well as the nurse practitioners in terms of their cannabis patients. I love to do some research in terms of what the home care or the CNAs in the home setting, what are they seeing, what's happening, and even in institutions or facilities, which is still kind of iffy because there's this stigma and legalities. There's only very few nurse practitioners as um, qualifiers to have that conversation with these home health aides or these caregivers or these nurses. So what do they see when they experience their patients using cannabis for medicinal properties?
Hmm.
That's the big one. And that's a whole lot. As we talked about earlier, the big another big thing in terms of home care, because as I said, I've always been in home care, is to look at what home care is now with the technology and to acknowledge the criticalness, the critical skills of the home care nurse. Because as I said, when I first started nursing, home care nurses really had a like, oh, they don't do anything, or they're not smart, or they're the ones that do home care because they can't make it in the hospital or bedside or whatever. So I really would like to start to look at the skills, because I know when I worked as a home care, there was so many things to do and so many things to learn. And with technology advancing, people with these 1 in 1 billionth condition that need uh, basic life support, they live much longer. They live into adulthood. They're not dying as a pediatric child. They live into adulthood. So that would be the other thing. And the biggest thing I'd love to do at some point is to really start to look at Black women and our health and our bodies, to look at what is it? Is it MetLife that set the standards for the BMI and all of that, and insurance, and see how that works? They say it's okay if we throw this out. It's
Hmm.
time to throw it out. It's time to look at it. But anyways, you sparked that. Thank you for that question.
Yeah, you brought some really great ideas to the surface that we'll have to revisit. What
Mm-hmm.
would you do if you could do anything for free?
What would I do if I can do anything for free?
Hmm.
Um, I will continue to do what I'm doing now, nursing, like having being on this podcast. If you call it free, it's not free, it's work, but I want to share the information and the knowledge, public health for public health. Yes.
We love that. If you could start over, what would you do differently?
I probably would have stayed in school. I know I would have tried to push forward when there was lots of doubt. I think the term now they're calling it what is it? I forgot the term. I can't even think of it. When you're not sure of yourself, or you're a little afraid, or you think you can't do it.
Oh,
I would
syndrome?
what?
Imposter syndrome?
Imposter syndrome. Yeah, I would really push forward and ask for help, because as nurses, we don't ask.
Nope, we
We
don't.
hide. We don't
We
ask.
suffer. We suffer in silos.
We suffer in a little silence, a lot
Mm.
of silence. Yes.
And who would you like to give their flowers to?
It's a few people I'd like to give flowers. Number one, I want my flowers. I want to give the flowers to myself. And the reason why I say it myself, because then I would share them. I would always have some flowers to share with someone. Yeah,
And
on a like
last,
a daily basis.
yeah, I love that. And lastly, what season are you in now?
I am in I want to say I'm with the elements. I'm in a real winter season where I want like to be like the bears. I want to eat. I want to sleep and hibernate and just wait for a little warmth. But in that coldness, when I say the hibernation, I just like to sit and think and let my mind flow and know that this is the highest point of this season, because I do think summer and winter, when we're at those high points, when it's too hot or it's too cold, we're supposed to slow down and do some other things. We're not supposed to be trying to keep going and keep going and keep going. I think we're supposed to slow down. So that, yes.
Wonderful. And so before we jump into our questions, if you could just
Mhm.
spend a few minutes just telling our guests a little bit about your journey and your backstory.
Okay, so as I was introduced, I just completed a terminal degree in nursing. I started nursing at the associate level. Lots of it was kind of like untraditional. When I got out of school, my last clinical day, I was like, "Ooh, what have I done?" And I let my clinical instructor know, "Oh no, I do not want to go into the hospital. I just didn't want to do it just yet." And I was a primary parent, and I was trying to figure out how was I going to do a shift and also parent. So luckily, she worked at a particular hospital and knew the nurses there. My same clinical rotation, I got hired through her agency, and I went back to the same clinical floor. So I did that for 8 months, where some of my colleagues was getting jobs and so on, and they was like, "Oh, you need to get this job." But after those 8 months, I was really mentored, I think, very well from some of the same nurses that I had done clinical with. And then I went into home care. And I'm saying that I went into home care because it was a lot more easier. You can work your schedule. I felt in control. So in nursing, I've always wanted to be in control. So I've done lots of home care at different levels, pediatrics as well as adults. After home care, I got a little tired and I answered a job. It was in the, I don't know if people remember when the nursing little magazines, they used to be hard copy. Anyways, it was part of this particular school was part of the YWCA in Washington D.C. They were the executors, so I was like, "Oh, this should be interesting." I didn't read it well, and I thought I was going to apply for some position at the Y or something. Anyways, I went down there, and it was called the Harrison Center for Career Education, and I got hired because the home health aid program was pretty much defunct. So I was hired to open it up, run it, and I did a lot of things, the recruiting, the budget, and so on. And I taught a lot of home health aides. And that was my beginning teaching. I started teaching and I found out that I was good at it and I had a passion for it. So I never left teaching. I taught them, I taught um, LPNs at the LPN level. I did a little work out the country as an embassy nurse in West Africa, Guinea, for a while. That was another eye opening because it at that time there were Guinea was very, very, very rural, even though we were in the city. No phones. We communicated by telephone. I worked with what they call regional doctors by way of the internet when it was up. And the biggest thing challenge was that what like my second day when I got there, I was like, oh my God, what have I done? Because there's no backup, no CPR, nobody to call. It's just you. So you make the decisions. And when you work in those environments like the military or embassy, the standards that are in what we work are a little bit different. You do everything, diagnose, treat, the gamut. I did that. Then I came back and started teaching and decided that, oh, I need to complete my educational journey. So I went back to school, got a master's, and worked in the hospital again for a few minutes. And I say that because I was dealing with a lot of level of racism, and that helped the imposter syndrome kick back in. I did that, and then I worked in same day surgery, and that's when I decided, okay, I'll do the terminal degree. I moved back to New York, and now I'm here.
And where are you
That's
from originally?
Florida,
You're from
South
Florida.
Florida.
You spent some time in DC. And
Hmm.
now you're back in New York.
Yeah, I'm in New York. Yeah. Hmm. Yeah.
And then the name of your DMP project?
The name of my DMP project is Epidemiology, the Implementation of the Cannabis Use Identification Test. It has an acronym called CUDIT, C like cat, UDIT, and it's hyphen revised. So it's the Cannabis Use Identification Test revised.
And we're going to get into more details with that, but that
Okay.
sets us up as to why you're the guest for today's topic.
Okay.
So let's get into a little backstory on the cannabis industry and how it's a growing market trend, particularly how it's being traded and everything. All the stuff you shared
Mhm.
with me during our session.
Yeah, so the cannabis market is, as they say, booming. It's $1 billion business industry because, as I shared with you, cannabis has long been traded in the stock market. You have lots of um, German companies, American companies that have been in the industry, and they trade. What has happened is filtering down, and people have become more knowledgeable and the access. And for some point, Congress and the powers that be have decided, oh, let's look at this again. And then they started the process of what they call decriminalization and legalization. And what decriminalization means basically, it's you're not going to get charged as you were charged 20 years ago. Of course, there's a lot of details in that, but you can have so much cannabis on you. You can grow so much cannabis. Of course, we have the dispensaries and so on. And legalization, of course, is it's legal per state. Federally, it's still illegal. So you have this caveat or catch 22. Cannabis is legal per 33 states by the time I did my project, and it's still on a federal level illegal, which imposes a lot of things. And imposes stigmas, barriers, and so on. Barriers to research, the industry that I'm most interested in, because it's very difficult to get for research unless you know somebody that knows somebody or you're with the powers that be. The also federally illegal, you cannot take it from state to state because each state has their specific laws. You're not allowed to use or carry it on airplanes or any federal constructs like your parks, your, of course, your federal buildings, and that on that level, which again imposes. Even though I know people, when you talk, as you say, in the back room, and people talk about how to carry it when they travel, what they do, how they place it, and so on, but if you go through let's say the airport, using the airport as an example, if you go through TSA, they do legally have the right to detain you and whatever it is that they're supposed to do. I've heard from some people who got stopped. Usually they'll take it and they'll just throw it, toss it, or whatever. But again, you're not supposed to take it from state to state. Federally, no federal buildings, constructs, or whatever. So that brings us to one of the things that nurses as well as the population should know. It is federally illegal. So you want to be mindful of your state's jurisdiction in terms of your cannabis use and your cannabis availability.
Thank you for that. That I feel like that even needs its own show, just like the
Hmm.
laws and the language
Hmm.
and how people know their rights, right?
Hmm.
That's important. That's so we'll need to jot that down for the future. So you mentioned the stigmas. What are some of those specific stigmas, and how can medical education help alleviate some of that?
So the biggest stigma is that around, as most people may call it, weed. I know when I was growing up, because of it being quote illegal. I think that's one of the stigmas that's associated with it's illegal. Some of the other stigma comes from the way cannabis has been used per street use, or what you call illegal use or recreational use. It's been mixed with certain additives, or what have you. So the stigma is that it's illegal, it's going to hurt you or harm you, and you can go to jail. That's one of the things. Even though, and I'm saying that lightly, because what I found out is even with all of that, through the use of time, people have always used cannabis. Cannabis is one of those, is one of the most, if I want to use the word, I've been looking for a better word, illicit use substances. I mean, people use it in ancient times for wellness, spirituality, rituals, partying when they just want to recreate, and definitely for their medicinal purposes.
Wonderful. And so, in terms of normalizing it, what can we do in medical education to help normalize those conversations?
To help normalize those conversations, the first thing as a practitioner is to have that conversation. And that conversation can start with just a question. Do you use cannabis or do you use medical cannabis? However you want to phrase it.
Okay.
As a practitioner, asking your patient, what else do you use for relief or wellness? Or what did you do? Let's say they are on pain medication. What did you do last week when your oxycodone, you took 3 and decided I'm not taking any more? To really start to have that conversation with them. And as a practitioner, on the practitioner side, again, especially specifically nurses, admit that you don't know and seek some information. Share it with your patients. From a public health standpoint or a patient standpoint, again, same thing. It goes vice versa. To start to have that conversation, if you start to feel that your practitioner is not knowledgeable, just ask, can they refer? And of course, I'll leave my information because there is cannabis is has evidence to show that it works for patients for their medicinal use. Yeah.
Yeah,
So
I
mhm,
think one thing going through the DNP program teaches us is how to have that systems level thinking, right? And
mhm,
so, the advice is great. We tell our colleagues and our peers, hey, you should ask your patients. But I think taking it to the next level would be to actually talk to the EMR or the IT department to see if they can put that specific question in the EMR, because that is what guides our conversations. I bring up what I have to document, and then it puts the language, makes it easier for me to ask that question. Because right now, the EMR I have is smoking, which when I say, do you have a history of smoking? Everyone will say, no, I quit 20 years ago. Yes, you have a history of smoking and you quit. So I had to change. I don't say, do you have a history? I say, have you ever? Because now that it's yes or no, you know.
mhm.
And so
Direct.
that's something I had to recognize.
Mhm,
They all say
mhm,
that. They all say, no, I quit 2 weeks ago because they've
mhm,
been in the hospital for 2 weeks.
mhm.
And I was like, you really haven't
Right.
quit. You just haven't had access.
Mhm,
And then the alcohol question. And then right now, the way REMR is, I think it's like illicit drugs, and which, like you talked about, when you frame it that way, I'm not going to agree to that. I don't do anything illicit, right? And so I think if we talk to our EMR and our IT department, we can take it to the next level, make that
mhm,
conversation easier, and make it
mhm,
easier for us to remember that we need to do it.
mhm.
Another fascinating industry trend at least I thought it was fascinating, is that older adults are the largest consumers. Can you give us some insight into that?
Yes. So lots of research, lots of studies show that the baby boomers are the largest consumers of cannabis. And some of that in my research, some of that I found because they're the baby boomers that come in, they were born in the 60s, the late 50s, and so on. So during that era, in terms of specifically in terms of America, teens, the youth were rebelling against, quote, the system. And they were using cannabis as lots of recreational cannabis, but in that, even though they were using it medicinally and so on, so they were, quote, bucking the system. But their use as they aged, their use of cannabis did not change, has not changed, never changed. So studies show that the baby boomers are the largest consumer of cannabis, and so they really have pushed the market forward. They've been the ones who have been advocating for the legalities books and writing about their use, their use. And so what I found out also, the ones who are afraid, were afraid, who had that friend that was okay with using cannabis, that is the friend they always went to.
Mm.
The grandmothers in the church and so on, they did go to their friend to get something for their arthritis or whatever. They, because what I found out, when you start to have that conversation, it opens up and they want to talk. They really want to talk. And especially since they it's been so-called legalized, the access, it, but what's not known, I'm finding out, is how to get the access and what is the access and how much and all of the safe access.
Yeah.
That's a conversation that needs to be had.
Yeah, I love your historical lens on this because my first assumption would have been, well, yes, of course, they're the largest consumers because they have the most comorbidities. And so they're looking for ways to alleviate that. But when you share how it was introduced to them, it changes it changes your whole perspective on it.
Hmm.
And I'm curious, do you see any differences in because you mentioned like how they're advocating for books and having it more accessible when it comes to socioeconomics or ethnicities?
Yes. First of all, the socioeconomic part of the whole cannabis industry, like you say, that could be a whole nother podcast. And give you an example.
You
So
should have this podcast because there are so many things that need to be talked about that really require
yes, it
that
is.
require their own episode that
Mm-hmm.
someone like yourself can do that.
Yeah.
Hi, I'm Alicia from the Melanin Initiative podcast. Our mission is twofold. One, to simplify complex health information so you feel empowered to ask questions, educated on how to manage your health, and confident to navigate the healthcare system. And two, to elevate the expertise of nurses, spotlight the diverse career opportunities within the healthcare industry, and inform our peers how to leverage their expertise as clinicians and entrepreneurs. In less than 2 years, we've grown to over 50,000 views and 1,000 downloads, with an international audience spanning the US, Canada, the UK, Australia, and more. Our engaged listeners are professionals, entrepreneurs aged 25 to 44 who value authentic, impactful content. Want to connect with this dynamic audience? Advertise with us. Send in your 1-minute video ad and let's amplify your brand. Email tmi.melanin@gmail.com for rates and details. Let's work together.
Because I was going to give you the example. So, New York, I live in the state of New York. So, New York says population should have safe access, da 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 da. Okay. I live in what they call, I live in Manhattan. And when I started my project and I would just do little research and started going to dispensaries, there were no dispensaries in this area. All the dispensaries are down 34th, 14th Street, that area. So if you're taking grandma and they want to use cannabis, how do they get down there? They have to get down there. The only dispensaries, or what I consider were dispensaries when I would do research and get lists, were somebody, they might come to your house. I mean, it's changed a little bit now. We've got a few dispensaries, but at one point, so in terms of the socioeconomic status, that is one entity, the access. The other part of the socioeconomic is the economic part of it in your pocket. It's, from what I've seen, it's like weed has been repackaged and is so expensive.
Mm.
Gone are the, you can't go to a dispensary and get what you called, when I was growing up and when I was an adult and first tried cannabis at 21, a nickel bag, quote unquote.
Yeah.
That's just not there. So that access. So then if you take the baby boomers, you know, the, not, you know, but us, black and brown, and these economic, most of them are on a fixed income. Where are they going to get the money? How do they get their access? Like the medical marijuana card. How do they get insurances to pay? Insurances right now, as I know of, if somebody is listening to this and you know something different, let me know. But as of now, they do not pay. But what I have found out, if you're working with a great provider, you can get your first initial consultation, which will help you get your card and have your provider bill it as your wellness visit, because it is a wellness visit. And that sets them on the road to get their medical marijuana card. So they feel a little safer. If they got their card, they are really feeling like, okay, I'm within the legal realm. So all of those entities, I am working on I love to do a class. I'm trying to work with the seniors to talk about how to get the medical marijuana card. What does that entail? And try to work with some providers that are willing to do that wellness visit so they can have their card. Because now we have a few dispensaries in the Bronx, South Bronx, and in the Manhattan area, like around 125th Street area, so they can go into a dispensary, even just to go in a dispensary to see. Because, the weed has been going in some store. I've heard lots of stories where you went in the store, you knocked on the door and the window slide and all of that riffraff, what I call the riffraff, to get rid of all of that riffraff. You still have some baby boomers here in the New York area. Yeah, they're sitting there, they're getting it from their grandson or so on, because the grandson is getting it from what you have is some of these illegal dispensaries, because it's a little bit less in terms of the dollar than your so-called legal dispensaries. And we have a lot of those in New York. I call them weed bodegas.
Let's talk a little bit about safe and informed use of cannabis now that you bring that up. The first thing I want to bring to our audience attention that you shared with me is that the state typically doesn't recommend that you smoke it. They recommend other routes. Can you tell us a little bit about that?
Yes. So New York specifically, because I'm in New York, I just want to say they don't advocate smoking because it's the inhalation. Even though there are studies out that talk about, there are pros and cons in terms of research, in terms of what it does and to your lungs and so on, and cancer and so on. But there are other ways to ingest cannabis to get the medicinal benefits, as well as if they're using it recreational. And I always use the story of Mr. Joe, if he want to hang out with his buddies and they're smoking and they're doing it recreationally, to teach him that he can get his buzz on or whatever be by other means. He doesn't necessarily have to engage in smoking, especially if he has a respiratory ailment or condition. So cannabis, you can, of course, always smoking. You can smoke it. You can do what we call another way of smoking, vape it. They have these inhaler pens that you buy, and it's the cannabis oil that they're vaping. You have pills. You can take it by mouth. So you have pills by mouth. You have tinctures where you place under the tongue. You also have sublinguals, like a candy, cough drop purse, similar to like cough drops that you can place under the tongue. You can use it topically, where you rub it, of course, on the skin for your conditions like your pain, your arthritis, your psoriatic arthritis. Also, of course, and you can infuse it into your food, drinks, your coffees, your teas. There are even beverages out there. The industry now, you can buy cannabis infused beverages. And of course, you can cook it in your food. It's not, when I say cook it in your food, infuse it, not just your brownies or your cookies or your candies like most kids are doing for recreational purposes, but you can actually infuse it into your meat, your fish, your rice, your beans, your cassava leaf, your stews, and so on. That whole shelf. I remember the first time I gain that knowledge about infusing into the food, I was really blown away. I was with a group of us, and we had a chef that cooked food and was showing us, and that was about 3-4 years ago. And then he kept saying, this is going to be really big, the infusing of the cannabis into the food, the day-to-day foods. Yeah.
Yes, it sounds fascinating.
Mm-hmm.
And I can't wait to listen to more about it on your podcast.
Mm-hmm.
So let's talk about the cannabis use identification test. If you can, tell us what it is and why it's used.
Okay, so there are a few cannabis tools or tools that are used to identify use, misuse, or cannabis itself. So the cannabis use identification test, the CUDIT tool, is a screening and assessment tool um, for practitioners to start to have that conversation. I picked this tool because I wanted to find out about cannabis use, real world research. You know, we can read books and we can speculate and we see on the streets what's happening, but to get an idea of what and why populations are using cannabis. The cannabis use identification test looks at things like have you ever used cannabis in the last 6 months? Did you ever spend X amount of time trying to get cannabis? Did you not do what you were supposed to do while you were high? Did you do anything wrong? Those questions they ask about their cannabis use. Have you ever tried to stop? And what happened? So I wanted to get that idea. The other part I added on the cannabis use identification test, because it has 8 questions. I wanted to add the National Council of State Boards of Nursing in their medical marijuana use guideline booklet they put out in 2018. They did research on 16 conditions and they tested the effectiveness of cannabis use. Cannabis, what I call raw cannabis, as well as synthetic cannabis. So in my research, I added those conditions because I wanted to understand why and what populations were using it for. I also left the other to just see what was happening. So what I found out with the cannabis use identification test, so it looks at some things as it looks at misuse, the level of misuse, whether or not it's critical or they need further assessment. So what I found out is that most people are what I consider overusing, not necessarily misusing. They're overusing. Most of the people are using it for pain. Uh, sleep was the number 2 in terms of why people were using cannabis, but lots of pain for chronic conditions and sleep, and of course some recreational. And then there was one, I was trying to find my research, I was surprised there was one condition that your post-traumatic stress disorders, your Tourette's, your, of course, AIDS, multiple sclerosis, cachexia for your HIV patients, your schizos, your epilepsy, and of course, the chronic pain. Now, let me say something about your epilepsy, your post-traumatic stress, and your schizophrenic syndromes, because there's lots of talk, or there's a segment that we talk about in terms of cannabis use and mental health, because you want to ensure that the patients are taking the correct amount of cannabis so they don't go over the threshold. It's not too much or so on. And you had asked the question about safe use. So this is one of the reasons why we want our patients to be safe. And we want to know why are they using cannabis. So the biggest caveat now, or what practitioners are saying initially for anyone that wants to start to see if cannabis works for them and if they like it for their medicinal use, is to start low and go slow. And you hear that a lot. And even though there are no specific guidelines, and this is what I'm finding of what we need, there is research that says maybe start with something at about a 2 milligram or a 2.5 milligram and wait, and then start to see if you need more or less, because the misuse of cannabis is real. To tell you a real story, I have a brother, my baby brother, had some pain at work, and he works with driving, not trucks, but those little toys where you lift stuff and so on. And of course, because we get cannabis information from TV, social media, friends, which is not always correct. Someone gave him a gummy. Here, take a gummy, because that's what's happening now. Take a gummy, and he called me, and someone took a picture of him. He couldn't work for the rest of the day. He was like, I'm never messing with that stuff. Da, 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 da. point is, so I said to him, well, how much was it? Of course, he didn't know it was a gummy. That's what he said. And it's like, what was the strength in all of this? So that's just why populations need this education in terms of cannabis use and how you can misuse it. Now, the greatest thing about cannabis is you can't overdose per se. I mean, you'd probably have to smoke, I don't know what the exact terminology, a whole field of weed at one time to overdose. Nobody dies because there are certain receptors in our brain that does not affect our respiratory system when a person is really high, so they won't die. They may be a little high, and you have to teach them to just kind of ride it out. And now let's look at what you took and let's work with building, finding your tolerance level or what works for you, because everybody is different. And this is one of the reasons why I did the research, because we definitely need some standards in terms of dosaging, because they are not. What I also found out that we learn from the patients, because the patients have been using it and they've been experimenting with dosaging, and they know how much they use and how well they slept, or how much they use to get through the day for their arthritis, or when they're feeling really stressed, like your post-traumatic stress disorders or your schizos, how much. And even though someone with schizophrenia or whatever, they definitely would have to be in a controlled environment, because it can work for their mental disorders.
Wow, that's so fascinating. I'm curious, when you looked at the research, because I'm not familiar with this tool. So when you see who is using the tool, is there like a trend on like certain parts of the country, different levels of providers, depending on the population that they seek, like, using the tool the most?
The tool or the use of cannabis?
The tool, the
tool. Oh, the tool is basically used with clinicians, researchers. We're trying to find out. There are lots. Yeah, researchers are using it. I saw in my research lots of practitioners in the Netherlands, Switzerland, places like that. I didn't necessarily find a great number of populations using the cannabis use disorderfication test. It's about 12, I would say, cannabis use or misuse identifiers to help. I chose this one because I liked the fact that it was 8 questions, and I wanted to identify some nurse practitioners to help me facilitate this, because the National Council of State Boards of Nursing has these, what they call 6 essentials that nurses should know. Nurses at all levels. They do have some specifics for NPs in terms of their education. But I looked at that and I said, so with these 6 essentials, patients should know this as well. If they're saying that, it's some specific things that you should know about cannabis, then the patients should know that as well. So I wanted to use these nurse practitioners to help. I gave them a class on the 9 essentials that they should have had in their curricula as a nurse practitioner, to either qualify or just have that conversation with their patients. So what I found out is that a lot, as I said earlier, a lot of practitioners are unaware of state regulations, whether or not they can have that conversation, whether or not their patients use cannabis. Now they'll say, oh, I know they smoke weed, I smelled it, or whatever, that kind of stuff. But it was never addressed. I also found out that practitioners are still, what I found out, some of them are still reluctant to have that conversation based on the legality, the decriminality, and what their institution, or what another patient may tell another patient that, oh, I had this conversation. They are not that comfortable yet. So that makes the patient uncomfortable. And for me, we're doing a disservice to our patients.
Yeah, I think lack of knowledge, first of all, I like I said, I wasn't familiar with the tool, and then time, right? So if it's not already implemented in the workflow, I would imagine you get some pushback and it would be a barrier to implementation. You said there's 8 questions. Do you know how long it takes to get those to complete the tool on average?
About 15 minutes or less.
That's long. That's
yeah.
that's the visit.
Okay, well, wait a minute. So let me say, okay, so that was my research. The tool itself, if I didn't add all these other caveats in the research, I would say that it would take about 5 to 7 minutes. because it's a 1, 2, 3, 4, never, almost
Oh,
never, that kind of stuff. And of course, depending on the reading acuity, I'm saying it take 15 minutes because I added some things. I asked them some specifics. What are they taking it for? But most people know already in their head, yes, I've used cannabis in the last 6 months. No, I didn't have, or yes, I did have trouble stopping once I decided to stop. Yes, I was stoned all day. Yes or no, I didn't do what I was supposed to do because I was high. It asks those questions. Yes.
given the time, I would think that it might be better. So, given the time of it, I would say, okay, this should be part of what the patient completes before the visit. But because you said one of the reasons you wanted to use NPs was to help start the conversation. So then I'd be scared that I'd be concerned if they complete it before the visit, will the provider still address it since the questions have been answered? But maybe it's just like the vital signs, like they've already been completed, but you're still going to address it in the visit. So, I could be optimistic and hopeful that even if we put it before the visit, that it will still get addressed. If it's in the EMR and they have to document that they talked about it, it will get addressed.
Yeah, so in my research, I also found what I found another tool. It's called the Brief Cannabis Use Disorder Screening Tool, and it only asks 3 questions.
Oh, okay.
So I was like, oh, this
Everyone
may be
listening,
better.
like,
When
oh,
you do research, yes. And I was like, oh, this may be a better tool
yeah,
to advocate for putting in the EMR.
yeah,
The one that I use could be a conversation between the patient and the practitioner. But that was one of the things when you're writing up, it's like, what can this tool be used for? And I said it should be in the EMR. But this brief identification tool that asks the 3 questions,
yeah.
I think that is a prime
That's a
tool
good
that
one.
could go into the EMR because only asks 3, and it starts the conversation because we can get to the rest later. And because it asks the first question, how often during the past 6 months that you find that you were unable to stop using cannabis? How often in the past 6 months have you devoted a great deal of your time to getting the cannabis, recovering from the use? And how often in the past 6 months have you had a problem with your memory or concentration? So it asks those 3 questions, and it's either never, monthly, and so on. That is a good 5-minute brief, and they can ask or they
Yeah,
can answer if they choose to answer. So
yeah.
I really enjoyed my doing the research, because as I said earlier, when as a young nurse and I started home care, I wasn't a nurse over a year. I did 9 months in the hospital, and then I went into home care. And what I noticed in home care, as I said, I was a primary parent, so I was like a Friday night, Saturday night kind of nurse. All day I'm in the house. I would always smell cannabis, and this was in the 80s. I a lot. I smelled it a lot, and I just used to think about it. Yeah, of course, we never had the conversations. I have some patients, of course, I smelled it. You just act like you didn't smell it or whatever. But in the 90s, I would say that's when I first started to have a conversation with a patient about their cannabis use, and I shared the story of the woman who had two kids, and all 3 of them were muscular dystrophy patients. And she shared with me that she used it because I came at a time when I guess she would be recreating on a Friday night with her friends. And I guess she said, well, I'm going to just say something to her. But she shared with me that she did it because it helped her relax after working all day. And she would be in her wheelchair all day, and it helped her relax once she could get herself from her wheelchair to her bed, and she slept. So that was the first time that I heard that. That was the first time I heard that in terms of medicinal use. That was, I think it was like in the 90s. The rest, because I used to think it's just recreation, or they just want to sleep and whatever. But it was just a very interesting conversation. I didn't say much. I just said, okay. As a nurse, I'm in her own. But it was the first time. And I think patients should be able to express, whether the caregiver or not is going to be there, is going to have that conversation with them. But the patient should be able to express and get referred out and know that they can have a practitioner or have a conversation with a practitioner.
Yeah, I think the QDIT tool, the way you're describing it, it sounds real familiar to the audit tool, which we use for alcohol. And those questions kind of also get to the idea of, has your drinking impacted your ability to function on a daily basis? And so I
Mm-hmm.
think the one you mentioned, the brief version, I think that's a great one, kind of like across the board. And then if you
Mm-hmm.
have someone who scores high, then maybe they'd be a great candidate to use the QDIT tool. And especially those of our friends who work in areas where they're treating that population a lot more, perhaps.
Mm-hmm. Mm-hmm.
They should probably also have access to it. So I think that's an actionable step for our clinicians who are listening. But really, I want to encourage everyone to take it up a level. Talk to the EMR, talk to IT. It's not just enough to tell people, oh, you should have this conversation. It has to be built into our workflow. And
Definitely.
then you mentioned the historical aspect of baby boomers when they started using marijuana and how they can, or cannabis, and how they continue to use it. And then you also said that the greatest use is in pain. And so I'd be curious, I wish they had been studied over a long period of time, because I imagine as a baby boomer back in the 60s and 70s, they were 20 and, teens, 20s. I
Mm-hmm.
don't think pain was the initial reason they were using it. But
Yeah.
over the course of time of, with age and wear and tear, so I would love to see data on that.
Mm-hmm.
And then you mentioned start low, go slow. So how do people measure that? Should everyone have a scale?
Lots of different kinds of tools, and this is something that needs to be explored even more. Uh, Talking with folks, they will say, well, I use this much. I use I have not, well, let me say this. There are I think I've seen about 5 different in the research uh recommendations. There are no standards, recommendations about how much to use and so on. With populations, a new user or someone, say if they go into a dispensary and they are buying, let's say they decide to buy some gummies, I think that is most important to teach them to go low and start low and slow, and what that really means. Meaning, I think I mentioned the 2 milligrams, 2.5 milligrams. Let's say it's a gummy and it's 2.5 milligram gummy and so on. If a patient uses one, the stress or the encouragement advice to tell them is to really say wait an hour or two. If it's a gummy, at least 2 hours for it to digest. Because when it goes into, if you're taking a gummy, it's going into the digestive system. It has to break down. So it's going to take longer and it lasts longer. It's going to take longer for the effect to come in, and it's going to last longer. That's a whole nother category in terms of how quickly the effect is and the lasting and so on. But so you want them to wait, because what we found out is that they'll take a gummy, and maybe after an hour, let's say they ate, got something in their digestive system, and it's like, oh, this ain't working. Nothing is happening because it didn't digest. They take another one. 2 or 3 hours later, when they're thinking they're gonna go to sleep and they are wide awake, it's dissolved and so on. But they've had 2 gummies. So that's why it's very important to start to work with them on an individual basis, to say, what are you looking for? What do you need? What do you want? And what do you want to happen? And what's your lifestyle like? Can you take pills? Do you do you not want to take a gummy? Let's say you're diabetic, or what we used to call brittle diabetics. You don't want anything shooting your blood sugar levels up. All of those things. It really should be tailored. Now, I'm saying that to say the American Nurse Association and the American Cannabis Nurse Association, they just came out with a book. I guess it's been about 6 months, maybe a year or less, with some standards and guidelines, but there's still no standards and guidelines about how much. There are individual books in terms of how much, going low, going slow, but that is all we have right now. How, the micrograms and milligrams, and there are no standards. In general, if you go to a dispensary, and I definitely will encourage anybody that's listening, just go into a dispensary and look around. You will see them. They will talk about I think, 2.5 milligrams, 5 milligrams, 10 milligrams per gummy, per pill, all of that. So you want to know how much and test it. If you start to ask questions, I recommend if a person goes into a dispensary and they start to ask questions and the person who they're talking to is doesn't seem that knowledgeable, you think that you're more knowledgeable than them, I will go to another dispensary. Here in New York, they are required to have a pharmacist at the dispensary. I'm advocating for nurses as well. You don't necessarily always need a pharmacist. A nurse could be there, but you definitely want somebody to be knowledgeable. Because I have found in dispensaries, and I started going in even here and in California, a few dispensaries I've been in the state of California. You did have staff that were very unknowledgeable. They were just selling you something. It's like if you go to the pharmacies and the pharmacy tech is there and you're asking, what's the difference between Actifed and Sudafed? They don't know. I mean, of course, it's on the back of the bottle, but they're not, it's like, will this make me sleepy? Well, that's the cold section, quote unquote, and that's what you're going to get. And that's what we don't want, because populations have gone into the hospitals where they've had too much cannabis. And talking to a few colleagues that work in case management or work in ER, they'll say the practitioners, would diagnose them with cannabis overdose because they may have been in pain. Let's say it was pain, may have been in pain, and they took whatever they took and they just was having an enormous amount of pain, and opioids weren't working. And then they try some cannabis and, after an hour, it still wasn't working. Then they go to ER, or they're really high and then they go to ER. Because they're, just trying to figure it out. Pain might be gone. And then they say, well, I took my hydrocodone or whatever they took, and then I had some cannabis. And now they're being diagnosed with a cannabis overdose because they are like really scared they had too much, coupled with the other drugs they took. Yeah.
Yeah, so we've mentioned the dispensary a few times. As we wrap up, can you give our guests who've never been to a dispensary, the nurses, 3 things everyone should do from a nurse's perspective when they go to the dispensary?
I would tell the person the 3 things they want to go. They want to go make sure that it's legal. It's a real dispensary, not a smoke shop like they have here in New York. You want to make sure that they're legal. Ask if they have a pharmacist or a nurse that they could talk to. As a nurse, once they've gotten that out the way, ask about tell the person that they're talking to what they're looking for. I'm looking for gummies, I'm looking for tinctures, or I'm looking for pain relief, I'm looking for sleep. I want something so I can sleep all night, or I'm looking for something to take the edge off of whatever. Then ask them to show you and ask about the strength and what's in the product. The other thing is to have them ensure that you can browse the products. I think here in New York, okay, let me give you an example. In California, you go into a dispensary and you can actually see the weed. I mean, it's covered, but you can actually see weed in glass containers per se. Here in New York, you can't necessarily see that it's covered. It's usually in a white container and so on. You can't actually see. So you want to ask about you want to ask about the weed. The third thing is to ask them about what you call your certificate of analysis, and that's a whole nother thing, because it has to be packaged correctly. Legal weed is packaged correctly, so you want to see if they have a certificate of analysis either on the walls to say how they ensure that their products are safe, or on the banister or the counter or whatever, or if it's actually on the product. You can only put so much on the product, but you want to ask them about the certificate of analysis, because I did ask one time and they were like, huh, what? So I would definitely approach it, and definitely always have an open mind. If you didn't find what you was looking for, go to another one. It's somebody's out there. So we're out there. Yeah.
Thank you. That's such good information. And you did mention making sure it's legal. How does someone know that?
Because they here in New York, there's an emblem that says New York. I forget what's the name of it, but it'll say the dispensaries will have the name on it. The difference between a real dispensary and what I call the weed bodegas, the smoke shops, you usually see it's a little smoke shop, and the weed is packaged with just in a package or something very pretty or so on. In New York, when you go into a dispensary, you have to show your medical marijuana card. They will not allow you in a dispensary. Anyone can go into a smoke shop
Okay.
and buy whatever.
Well, you have given us a wealth of information and a lot of things to think about, some actionable steps, both for our clinician friends as well as the public. And we look forward to that book, those training workshops you're going to offer dispensaries so that they can have an educated staff on board, and you publishing more, right? Because you identified gaps in research.
I'm working on a book called the Cannabis Code Book.
Oh, okay.
Mm-hmm.
And maybe that's the name of your podcast too. Help promote the book. Okay.
So
How
the
can
book should come out, where are we? In January. It should come out around November of this year.
Oh, okay. Wonderful.
Mm-hmm. At the end of the year. Mm-hmm.
Okay, great. Well, how can our guests connect with you?
They can connect with me by my email. My email is Willa Smiley. That's W Smiley at The Worth Continuum, and I'll spell it. It's TheWorthContinuum.biz. TheWorthContinuum.biz. And they can also go to my website. It's called The Worth Continuum. TheWorthContinuum. The Worth Continuum. Because I believe that our value is based on how we understand and know our worth.
Great way to close this out. We will have all your social media links, website, and all the information you share with us will be in the description box, as well as all the resources that we mentioned. We can't thank you enough for lending your time and talent with us, helping us continue this conversation. And I believe these conversations do help to address the stigma and normalize the conversation, make it more safe for people to, raise their hand and say, look, this is something I think that I just want to know more. Right? Maybe they just want to start that conversation as you have encouraged us. Remember, everyone, you can email us your questions and show ideas to tmi.melanin@gmail.com. If you haven't already, there's still time to subscribe, leave us a thumbs up, share the content, rate us on Apple and Spotify. When you engage with our content like that, it shows the algorithm that this information is important, so that when people like you look for information like this, we'll show up higher in the search results. At the time of this filming, we release new videos every Sunday at noon Eastern on YouTube, Facebook, and LinkedIn. And then we drop the audio at 5 a.m. on all your favorite podcast apps, so our night shift friends can be the first to get something and not the last. And maybe one day someone will play it during huddle and tell us about it. We thank you all for watching. We'll see you next time.